Dr. Brian Shepard from UNOS was unable to make this meeting, so I was asked to say a few words about what we call donation after circulatory death, or DCD. I'll be using DCD in the United States. So I have no slides, but I would like to address just a few major points. So one, DCD has become a very important contribution to organ donation in the United States, and over the past several years. And with its implementation into our care and transplantation care, I think three things had to be addressed and are still being addressed. So one is logistics of donation after circulatory death. Second is determination of outcomes for patients who receive solid organ transplantation with donors after circulatory death versus donors after brain death. And third, to examine whether DCD could be affecting donation after brain death. And I would like to very briefly touch on each of those. So as far as the logistics, and as you might have already guessed from some other presentations, the donation transplantation field is fairly regulated in the United States. So pretty significant expectations and targets are given to organ procurement organizations and transplant centers. So as DCD is part of standard transplant care today, the organ procurement organizations in the United States have targets to achieve as far as the number of donors after cardiac death. And I think in the United States overall, on average, donation after circulatory death now varies between 20 and 30% of all donations. So only 70% of our donors are now brain death donors, roughly. And so in connection with that, also the organizations that are regulating the hospitals have set up a mandate that each hospital needs to have a plan for donation after circulatory death. Meaning, if there's a patient, and not just transplant hospitals, every hospital. So if there's a potential donor that expresses their wish to donate organs after circulatory death, the hospitals need to have guidelines on how to achieve that. And the two main ways that has been done is either to withdraw care in the intensive care unit and then to transfer the patient very quickly to the OR, or actually for the family to say bye to the patient in the unit and then transfer the patient to the OR, operating room, and withdraw care in the operating room. So, as you can imagine, this provides added complexity to the donation process in the hospitals, and also is a change for the families that in the past were expected to be approached about donation after brain death, and now there's this new process where the patient is not brain dead, they're still on life support, they are not considered dead, but they are being approached about donation after their heart would stop. So here, and I know we have many members from OPOs and members who are in the social workers and members who are involved in this donation process, we have found that it's extremely important that it's the organ procurement organization members that are very well trained in approaching the families and explaining that process, that are the primary members that approach the families and explain it to achieve a high acceptance rate from the families. So that's the logistics. The second question we've had at some point is, now that donation after circulatory death is being more and more accepted, could actually this decrease the number of patients who progress from condition with very poor prognosis to actual brain death? And after some investigations in the past 2 years, it actually does not seem that has been happening, but we clearly need to keep that in mind, that if there's an organ donor where it looks like herniation will occur in the next few hours possibly, to try to be patient after donation, after brain death, still the opportunity for the recipients is higher as we can use more organs. And finally, there was a question, could outcomes be different as we are having more ischemic time with donation after circulatory death compared to donation after brain death? And the investigations that have been done so far, both in abdominal transplantation and most recently in thoracic transplantation, where actually the registry of the International Society of Heart and Lung Transplant helped to conduct a pretty large study in DCD lung transplantation, suggests to us that post-transplant outcomes are equivalent to donors after brain death, and it is therefore expected that donation after circulatory death will further increase. And I would like to just finish up with a little look to the past, because as you know, in heart transplantation, we do not use donors after circulatory death, but a little bit look to the past. In the 60s, donations started before we had the concept of brain death, and the first heart transplantation performed by Christian Barnard in South Africa actually was a donor after circulatory death. The team waited till the heart stopped and then procured a heart, and that's how procurement was done. So I think sometimes it helps to look a little bit into the past, because as we now think DCD is a completely new thing that we are implementing, it was actually done back in the 60s, and so I hope that in the future we'll be able to even include heart transplantation in the realm of donation after circulatory death. Thank you very much for your attention.